Hey everyone, welcome to today's Explainer. I am absolutely thrilled you're here because we are unpacking a truly fascinating medical mystery. Today, we're zooming deep into the human brain to look at the pituitary macroadenoma. We're going to explore how something so incredibly small, I mean literally the size of a pea, can completely hijack the body, rewrite our chemical code, and just orchestrate profound changes from head to toe. It's a wild journey into the delicate architecture of our minds, so let's dive right in. So right off the bat, we run into this massive paradox. When you hear the word benign at a doctor's office, you usually breathe a huge sigh of relief, right? It almost always means non-cancerous. But as we're going to see, benign does not necessarily mean harmless. If a benign mass grows in the absolute wrong place, it can trigger massive neurological and hormonal chaos. It just goes to show that when it comes to the brain, location is everything. All right, part one, the 10-millimeter hijacker. Let's pinpoint exactly what we're looking at here.
Okay, so a pituitary macroadenoma, it's a benign tumor of the pituitary gland, but the magic number here, the threshold we really care about, is exactly 10 millimeters. That is where the immense danger starts. You see, the pituitary gland, which is often called the master gland, sits in this tiny bony vault at the base of the skull called the sella turcica. Because of this rigid bone casing, there is absolutely zero room for expansion. Taking up even a fraction of extra space in there is kind of like blowing up a thick balloon inside a small steel box. It just relentlessly crushes everything around it, leading to devastating neurological problems.
The way we classify these things is actually super straightforward. It's based purely on size. If the tumor is under 10 millimeters, it's a microadenoma. If it hits that precise 10 millimeter mark or goes over, boom, it graduates to a macroadenoma. And if it somehow gets past 40 millimeters, which to put into perspective is roughly the size of a golf ball inside your head, it's classified as a giant adenoma. Crossing that tiny 10-millimeter line completely shifts the reality for the patient. It transforms a manageable quirk into a full-blown systemic threat.
Moving on to Section 2, Pressure and Vision Loss.
Now this tumor attacks the human body in two completely distinct ways. First up is what we call the mass effect. This is just brute-forced physical compression of nearby structures. It's purely a spatial problem. Then you have the hormonal effects, where the tumor acts like a rogue chemical factory, causing massive hypersecretion of hormones or suppressing the healthy gland completely. To really wrap our heads around this, we need to look at the physical mass effect first.
Since real estate inside the skull is strictly limited, a growing adenoma physically squishes whatever is next to it. That translates to severe, unrelenting headaches. But here's where it gets crazy. As the mass pushes upward, it compresses the optic chiasm. That's the exact intersection where your optic nerves cross. When that gets squeezed, it leads to a terrifying symptom called bitemporal hemianopia. Basically, patients slowly lose their peripheral vision, like the world is closing into a dark tunnel. Honestly, a routine eye exam for clumsy peripheral vision is often what actually uncovers the brain tumor. Also, if the tumor grows sideways into the cavernous sinus, it hits the cranial nerves, resulting in diplopia, or severe double vision. It can even squash the healthy pituitary tissue until it just gives up entirely, which is a state known as hypopituitarism.
All right, Section 3, the hormonal havoc. Let's shift away from physical pressure into the bizarre chemical clues.
This is where the clinical picture turns into true bodily chaos. We're talking about functioning adenomas, tumors that actively and continuously pump out excess hormones. The real-world effects are absolutely wild. A prolactinoma pumps out massive amounts of prolactin, which can cause unexpected lactation, known as galactorrhea, along with amenorrhea and severe infertility. A growth hormone-secreting tumor acts like a runaway growth engine. In adults, it causes acromegaly, visibly thickening the bones of the face and hands, while in kids it causes outright gigantism. An ACTH-secreting tumor dumps extreme amounts of stress hormones into the body, leading to Cushing disease, which means rapid weight gain and fragile skin. It is literally as if the body's master chemical control board has completely short-circuited.
Contrast those noisy, hyperactive tumors with non-functioning adenomas. These guys are the silent, stealthy threats. Because they don't secrete excess hormones, they fly completely under the radar for years. They present really late in the game, usually only getting noticed when they've grown large enough to cause those severe physical compression symptoms we just discussed. And while they're hiding out, they're silently choking off normal hormone production, quietly leaving the patient fatigued, weak, and hormonally depleted before their vision finally starts to fail.
Okay, Section 4, Investigating the Sella. Let's play detective.
How exactly do medical professionals confirm this culprit hiding deep within the skull?
Well, clinicians follow a strict 3-step protocol. Step 1 is the absolute gold standard, an MRI of the sella with contrast to get a high-definition visual of the mass itself. Step 2 is a thorough visual field assessment to precisely map out exactly how much optic nerve compression has happened and what parts of the patient's vision have gone dark. And step 3 is mapping out the chemical evidence through a comprehensive hormonal profile to see the damage done to the endocrine system.
To properly map out the tumor's hormonal footprint, they have to run a massive, sweeping biochemical panel. They're testing prolactin, IGF-1, cortisol and ACTH, TSH and free T4, LH and FSH, and sex hormones like testosterone or estradiol. They cast an incredibly wide net because they need to see exactly which specific systems the tumor has hijacked to overproduce and which life-sustaining functions have been critically suppressed. You're basically reading the ransom demands of the rogue tumor.
When that MRI finally comes back, clinicians read it like a battle map. It gives you the definitive crime scene photo. The scan clearly highlights the main mass, but more importantly, it exposes the collateral damage. Is there a clear optic chiasm compression? Has the mass invaded the cavernous sinus? Or in extreme and sudden cases, is there evidence of internal hemorrhage? That would point to a catastrophic event called apoplexy.
Which brings us to Section 5, Treatment and Apoplexy Emergencies. We've arrived at the resolution of our medical narrative. The treatment path here brings up a truly fascinating medical distinction. For prolactinomas, the first line of defense isn't actually surgery. It's entirely medical. Using dopamine agonists like carbogaline can magically shrink the brain tumor just by having the patient take a pill. It's an incredible pharmacological victory. However, for non-functioning macroadenomas causing dangerous compression, or for those stubbornly hormone-secreting tumors, surgeons have to go in physically. The go-to is a surgical transsphenoidal resection. This means the neurosurgeon literally navigates straight through the nasal cavity and the sphenoid sinus to remove the tumor from the bottom up without ever having to open the top of the skull. Now, radiotherapy is kept securely in the medical arsenal as a highly effective backup plan. It's specifically reserved for residual pieces of the tumor that were just too dangerously entangled in brain tissue to safely remove, or for aggressive tumors that stubbornly keep coming back. But we need to shift gears for a second, because there is a high-stakes, life-threatening climax to this condition that you need to be acutely aware of: pituitary apoplexy. This is a true drop-everything medical emergency.
Apoplexy means there has been a sudden, catastrophic hemorrhage or rapid tissue death right inside the tumor itself. Because it happens in that closed, bony box we talked about, the resulting pressure spike is terrifying and immediate. Clinicians have to suspect apoplexy when a patient suddenly presents with a thunderclap headache, often described as literally the worst headache of their life. This is usually followed by rapid visual loss, ophthalmoplasia, which means the sudden paralysis of their eye muscles, or an altered state of consciousness. The danger to the brain here is profound.
When apoplexy strikes, there is zero time to wait. Immediate action is required to save the patient's life and rescue their vision from permanent darkness. The protocol involves administering high-dose hydrocortisone right away to support the failing adrenal system, paired immediately with an urgent neurosurgical evaluation to physically decompress the space and relieve that massive pressure crushing the brain. But to reassure you as we resolve today's mystery, the overall prognosis is actually incredibly hopeful. With appropriate, modern treatment and early recognition, especially if we catch the mass before the optic nerves take permanent damage, the outcomes are generally excellent. While a patient might require lifelong endocrine follow-up to carefully manage their hormone levels, they can go on to live a completely full, vibrant, and normal life. Which leaves us with this final thought to ponder. We've seen today how microscopic structures hidden deep in the dark vaults of the skull hold immense, disproportionate power over our physical reality. If a benign mass measuring just 10 millimeters can completely rewrite your body's chemical code, trigger impossible growth, and steal the edges of your vision, it really makes you wonder, who is truly in control? Keep asking questions. Thank you so much for joining me on this explainer, and I'll catch you on the next one.